my friend here, Herb, is a 30-year military veteran, 10 years active duty, 20 years reserves, and he has, government health insurance because as a retired member of the military, his wife has insurance through her job, and he goes to the VA. And there's a stigma around the VA in certain circles of, oh, nobody goes there who doesn't have to. And I was thinking as I was driving that there's actually there's a cohort of vets who prefer the VA. And yes. I met them when I was in training, and they go as far back as the World War II crowd. And I was curious, I have suppositions, but I was wondering what Herb's story about that was.
I would be interested in that as well.
I'm just comfortable. There are other veterans there that I'm comfortable with. The doctors and the nurses there take their time with me. I'm not rushed, and it's great medical care. More than once, they've literally saved my life. So, and there are other things besides just the health care that they do for veterans who are disabled that I like to participate in. So that's why.
And you've had, because partly related to your military service, you've had some major medical needs. You don't just go there for a flu shot. You've needed some serious care from them.
Absolutely, absolutely.
You say you feel comfortable around other veterans. Does it remind you of the health care you got on active duty, or is it simply that? Tell me a little bit about being in the company of other veterans.
It's being in the company of other people who've gone through some of the same things you've gone through. And even though we don't always talk about those experiences, mm-hmm. When we do, it's a bond that's formed, and it's a sense of camaraderie.
I got caught up in a conversation the other day with some really adorable young Army guys at the base who were getting me onto the base to go to the post office. Mm-hmm. There's a whole language around being in the military, lots of acronyms, mm-hmm. and mm-hmm. Is that a piece of it? It
probably is. Okay. And the, excuse me, the acronyms are so common for us that we don't even realize that we're speaking in Army speak. It probably is. Yeah.
The VA. So have you gone for health care in the private system?
I've had a couple of surgeries where I've had to go to use private doctors, and they've been fine. And I had a great relationship, a great experience. I actually have the doctor who performed the 2 surgeries on me. He and I actually, he's a tall guy. He's about 6'7", actually a little taller than I am. And we had kind of had a running joke because he had a nurse that was very short. We kind of teased her a little bit. But even with that, I still prefer the VA. And it's because I know that he's on a schedule, and mm-hmm. he can only see me for a few minutes, mm-hmm. and then he's off to the next one. Whereas if I go to the VA with my primary or with one of the other specialties, if I need to be there for an hour and a half, it's okay. I know they want to know what's wrong with me or whatever the situation is, and they want to fix it. And I never feel rushed.
So the VA is unique in American medicine in that it does not bill. Mm-hmm. In U.S. medical care, I was at a meeting with the local medical society, the Tidewater Medical Society, and mm-hmm. we were talking about, I forget what, and the doctor sitting next to me said, well, it depends on whether it gets reimbursed. If it gets reimbursed, it'll get adopted. And I thought again to myself, I remember the VA. They never talk about that stuff.
No. I mean, that's not something I'm aware of.
Okay.
I just know that the unique thing about the VA and the one I go to is in Richmond is they have a very close relationship with VCU mm-hmm. or MCV. Mm-hmm. And I had one situation, a very serious situation, where I was in the hospital for about 10 days. Mm-hmm. And the doctor who came in, the guy who was in charge of my treatment, mm-hmm. was a doctor who also worked at MCV. Mm-hmm. And he took his time, he took his time and explained everything that was going on and all the options that they looked at in my case. Mm-hmm. And I just felt like if something goes wrong, I'm in the right place. And you know, I can't explain. It's like a soldier when you go into combat. You don't mind taking that extra risk because you know you got some folks behind you that are going to take care of you. And that's just kind of how I feel when I'm at the VA.
So that's interesting to me because my most intimate experience with national healthcare was in New Zealand. And I was there for 5 weeks when I was in medical school. I was not a participant, but I was a medical student. I mean, I didn't get sick, I didn't have to go to the hospital. There was a sense there that there's only 4,000 of us, 4 million, we're on an island in the middle of the Pacific. We've got to make do with what we have. And if I take too much, then my neighbor doesn't get enough. But that all in it together piece of it, it's not just about me. And you think you get that feeling at the VA?
Absolutely.
Okay.
I think that you know, when you walk through the halls of a VA, you see the sacrifice people have made for this country. And even though some have sacrificed more than others in that situation, some folks didn't come back. But so I just, there's a sense of camaraderie. There's a sense that, you know, we're all, you know, we're here because we want to be. You know, I had one of the practitioners tell me the reason he loves working at the VA is because he worked in the private sector, and folks would come to their appointments late and still want to be seen. And the thing about the VA is, you know, with the military discipline, most guys come early. You know, they're an hour early. There have been times when I've been in the waiting room, and I've seen neighbors or folks who I've served with who I hadn't seen in a while, and because we're early, we can kind of catch up on stuff. And I can't, you know, I can't explain it, but it's just, you know, I'm just very, very comfortable when I know I'm going to the VA, and I probably have appointments there probably twice a month, and I try to have them all together so that, you know, if you know, I don't have to go back, you know, a couple of days in a row. I can kind of take care of all of them in one day.
There's physicians who are in practice now complain a lot about their electronic healthcare records. At the VA, what's your sense? Do they spend all their time looking at the computer, or they have time to look at you?
Well, my primary, they're looking at me. They're talking to me. You know, I know that they're taking notes, but they're talking to me, and they you know, they're doing a pretty good job because we have electronic healthcare records that I can actually access.
Oh, okay.
Yeah, and they're fairly accurate. Yeah.
The VA healthcare system is unique. It was actually written by some doctors starting in the 70s, and it's uniquely structured, and they're going to do away with it and go to one of the commercially available plans, and fortunately they picked the same one that the DoD is using, so at least hopefully there'll be interoperability down the road. But I'm really mourning the loss of the VA EMR because it doesn't have any billing component. It was written by physicians. Apparently it's really hard to find coders for the language now, so maintenance is an issue. But the other thing about it is the way it's designed, it's very light on the end use, and so you just need a really good server in the basement, and the whole hospital can run very quickly. You don't have to have expensive terminals. At least that was true 20 years ago. Who knows what it's like now, but yeah.
And I also feel like the VA, the staff is probably there's a great deal of stability there.
I think so.
You can go there for a while and you see people. When you're in the private system in our country, you often are forced to change providers if you're getting an employment provider health insurance, because they make a business decision every year on health coverage, and the business may determine we're going to change the entire company and then no longer in the network. Our family's had 3 straight years, 3 straight primary care changes, which would not in any way have been our choice. So that must be a great aspect, just the stability of it.
Yeah, I mean, I've had one doctor change at the VA, and that's because the doctor, my primary that I had, he decided he wanted to do research, and so And actually, my primary now is actually a nurse practitioner.
Uh-huh.
And you know, if I have an issue, I have her cell phone number, which is, I'm not sure that's the case with everybody, but I have her cell phone number, and if with some of my situations, with some of my ailments, if I feel the need, I can pick the phone up and call her, and she might be, she's calling me back while she's on vacation.
I've
So-
handed my cell phone number out, and it's never been abused.
Yeah.
You know, it's usually somebody who, the fact that they can reach me for 5 minutes will save me, them, and other providers hours.
Right.
Yeah.
And so, because we know each other, we know the situation,
Yeah.
and we can fix things on the fly.
Yeah. So,
And save hours and save a lot of money in the system.
So the nice thing about the VA is we're not, and I don't work at the VA, but the nice thing at the VA is that's not part of the equation.
Right, right.
yeah.
It's saving Herb the time from going in, it's saving
Right.
the VA folks at the ER the time from having to learn his chart so that they can help him and do all the paperwork. She can just, okay.
So you mentioned the word abuse,
Uh-huh.
and I can honestly say that I don't believe veterans are abusing the system. I think that veterans are going to use it when they need it. The sad thing is there are a lot of veterans who don't use it, and they should be using it. I have a friend from Afghanistan who needs therapy. There have been some times where I wondered what he was going to do next, and fortunately he hadn't done anything. But he needs to go to the VA. He needs help. He's going through some things, and I know he's not alone. There are a lot of veterans
Right.
who refuse to take advantage of the benefit that they've earned, and a lot of those 22 veterans that are taking their lives every day are a prime example of that. I had a first sergeant that was, you know, he was an absolutely great first sergeant, and almost 4 years ago he took his life, and I think that had he reached out to the VA, he'd probably still be here. So I don't think that the system's being abused. I think the system's not being used enough.
I actually, when I was giving out my phone number, it was I was working in a safety net clinic, so I was working with the uninsured, people who, most of whom are now on Medicaid with adult expansion. But there's a lot of anger. People don't like other people getting something for nothing and think they're abusing the system, and that has not ever been my experience.
Well,
They're I'm trying not to swear on camera, but you know they're jerks in all income brackets.
well, my mother worked at the VA in Salem, Virginia, so I was familiar with it, but didn't fully understand it.
Yes.
And my mother dealt with a lot of guys from World War II, and the Vietnam War, and the Korean War. And I just believe that as a country, when we make a decision to go to war, part of the cost of that is taking care of veterans who put their lives on the line for this country. So, and so if somebody thinks that a veteran's getting something for free, they're just wrong.
I'm talking about civilian patients.
Well,
Yeah.
but
But people will say we shouldn't take care of refugees because we don't, until we take care of our veterans. And I'm like, we don't not take care of our veterans because we don't take care of because we're taking care of refugees. We don't take care of our veterans because we've made choices as a society that we're not our brother's keeper. And the VA is an example of a group that feels responsible for each other. You know, New Zealand was an example of a country where 4 million people felt responsible for each other. Is that dead in the United States on the general
it's certainly
level?
changed. I think once upon a time, the United States. I think there was a common attitude. I mean, World War II is a prime example of that. Germany was destroyed, Japan was destroyed, to a degree, Korea, and Vietnam even. And the United States essentially rebuilt all of those countries. And I think we're getting away from that. I think that we're more about, taking care of us and America first. And I think that.
But we're not taking care of America.
Well, I'm telling you what I think what the attitude is, and I think we're looking at this. I think the attitude needs to be the whole world as a community. Mm-hmm. If we're as the most powerful country in the world, I think we have a responsibility to try to move the entire all of humanity forward. I think that's a shared responsibility. I think that if we don't, we have people who are coming in here who are refugees, mm-hmm. and if we don't treat them, since we're on healthcare, if we don't treat them, mm-hmm. and they come down with some disease, mm-hmm. then that could be potentially catastrophic for the entire country. Correct. If we don't treat it. Mm-hmm. So it's not like they're getting something for free. It's a public health issue that we need to take care of.
I got asked by somebody whether I supported giving free health care to undocumented people. And I said, well, I support giving free health care to you. And so in order to give free health care to you, I have to also provide it to undocumented immigrants.
Yeah, I mean, by providing health care to them, you're actually protecting yourself. Yeah, I mean.
Yes, but also in order to provide universal health care. So my ideal would be sort of the British system, free at the point of care. Everybody can get care. I don't have if you get true coverage for everyone, you're going to take care of people who don't have paperwork because you're not checking.
Right.
I agree.
Yeah.
I agree.
And the other thing, no. I was going to wander over onto the real ID topic, but I think I can stay away from that.
Dr. Ella, what you don't know about me is my major was actually healthcare administration. I don't know if I told you that before.
I think I did know that at one point.
Yeah, and I was actually a medical service corps officer in the Army my first 10 years. Okay. And then when I left active duty and went back to school, I was a medical service corps officer, but I specialized in logistics for the last 5 years of my active duty service. And the Army actually sent me back to school to get an advanced degree in logistics and acquisition management. So when I did that, I actually didn't really get back into the healthcare field for the most part, but it was logistics. But I understood healthcare because by virtue of the fact that I had a degree in healthcare, actually, my parents were both in healthcare. And my mom was a nurse and my father was a lab technician. And my plan was to study healthcare administration because I wanted to meet a nurse. And it didn't quite work out that way. I ended up marrying a school teacher, but that was, there was a method to my madness when I decided to study healthcare administration.
Well, I was the deputy health director of a health district for a year, and I'd always known that it's a system. I have an analogy that Grace likes, but patients are the eggs, and doctors are the chickens, but the nest is the system. And if the nest is bad, it doesn't matter how good that chicken is. The chicken could be the best egg sitter in the world. The eggs, if the nest has holes in it, the eggs are going to go splat. And if the nest is rigid and made out of concrete, then the chicken's going to crush the eggs because there's not going to be any give. And the doctors don't. Yeah, the doctors don't make the nest. The nest is built by nurses and lab techs and people who do logistics. Yeah. But when you're facing an emergency, the fact that you can reach over and grab what you need started, with somebody making the list and then somebody else figuring out how to get it and then somebody else figuring out how to make sure that it got restocked after after you used it.
It's a team.
Yep.
It's a team.
And I wanted to underline the point you made earlier about how we've made choices, which is why we're not taking care of veterans as we should, or about not taking care of refugees. But we've made choices, but we clearly have in abundance the resources to do that as a country.
Oh, good grief, yes.
Absolutely, yes. And so it's not a question of having to sacrifice for that.
Yes, so yes, however, our healthcare costs too much.
Right.
We spend the largest portion of our income on healthcare for worse outcomes
That's right.
than any of our peers.
Yep.
And it's interesting because it isn't, so we are fatter than the average European, and we eat worse, but we're not fatter or worse than the average Briton. So if you were going to compare us to the UK, we both do a lot more and we pay more for it. One of the things we've been talking about here in Virginia is, well, we've been talking about it, is outpatient prescription drug costs. Everybody's fatushed, upset about it. People are wanting to introduce copay caps. Well, that's cute, but it doesn't really get at the underlying problem, which is that the actual drug costs too much. You were talking earlier about having to change your doctors. There is a model called single pricing, which is where the price for services is established. And it doesn't matter who the payer is, the thing costs what it costs. And if we went to single pricing, so in the United States at this time, switching to single payer would probably, the amount of industry disruption and the amount of political resistance, I don't think there'd be the political will for it. But we could talk about single pricing. And we know that outpatient pharmaceuticals is a small enough, it's a piece of the puzzle that can be separated from the rest of it, because companies already do it with their prescription benefit managers. And prescription benefit managers are the biggest racket going. And we've reached a point where they own some of the chain pharmacies. And so they give preference, reimbursement-wise, to their own pharmacies, yes. Also, you have to call around to find out how much your medication is going to cost, and that's just ridiculous. There has to be a way to set a formulary for the state of Virginia where the cost of a medication is negotiated between the state and the supplier and is published. And so, and then the reimbursement rates are also public and published, and you know, there needs to be a profit margin for the guy at the end user, the pharmacist. But I think there's a couple of different ways to go after it, but I think we can do it. The thing is, everyone's going to say, "Oh, you can't do that." And of course you can. We regulate the cost of alcohol.
I mean, try to.
Exactly.
Yeah.
Have you tried?
Yeah.
And do you think, with the whole opioid crisis and the whole involvement of some people, we're at a place where we can make bigger reforms because maybe more things are on the table politically?
I think the cost of insulin is the thing that's really going to drive this, because a type 1 diabetic becomes diabetic in childhood.
Right.
And it's a disease that has no victim blaming.
Right.
And they truly die without their insulin. And so I think the cost of insulin actually is the thing that's really gonna, that and chemotherapy and immunomodulators for people with MS and rheumatoid arthritis and inflammatory bowel. Those are the things that I see people, there's no victim blaming.
Right. Right.
And they're outrageous, and they don't need to be, because if you go look them up on the New Zealand formulary,
Right.
and you can do that from America. You can go to the internet and find out how much something costs in New Zealand for a cash-paying patient who is not receiving government subsidy.
Right.
Yeah.
Depending where you live in Virginia, you might not be able to do that at home, but you can do that on the internet.
Find
Some
out.
places in Virginia that don't.
Oh, yes.
So that's a whole other issue.
We have other plans about
That's
that.
another
Okay,
story. Yeah.
You have a plan for that?
Of course I have a plan for that.
Well, actually, in terms of reaching veterans at risk of suicide, is it something Virginia or communities of Virginia can do more, do you think?
That's a great question. I'm sure you've been in your car and you've been at a stoplight or a stop sign and you've seen a guy in the median. Most of the time, those guys are veterans. And every time I always try to give them $1 or $5 or whatever. And if the light's long enough, I'll talk to them and say, "Have you been to the VA?" Universally, it's I don't have time. It's just too hard. It's too difficult. And I don't know. I'm not sure if that's really the case. So I don't know how to reach those guys. I mean, you know, I didn't know my first sergeant had a problem until he was already gone, and then I talked to his wife, and you know, in the wake of it, you know, a few months afterwards, and she was telling me how he had deteriorated, and he started drinking, and it was clear in his behavior he was deteriorating. And he knows about the VA he was my first sergeant, so he was in charge of taking soldiers. His job was to take care of soldiers. He knew, you know, what he could have done, but for whatever reason chose not to. So I don't know what the answer is. I just
Would she have reached out?
That's a good question. Because I never asked her that question.
Because the people who panhandle on the sides of streets are kind of a unique group, and there's usually more going on than that they're veterans, and some of them lie about being veterans. But the ones that I worry that we're losing are the ones who have homes, because that's where they're sitting with their homes, and that's where they're keeping those guns they're using to kill themselves. And it may be that it's family members and that we need to help.
Yeah, that's
to reach out to.
Yeah.
And not just wives, but girlfriends and children and brothers and cousins and.
Yeah, I think.
I mean, we send two soldiers to someone's doorstep to tell them that they've lost their child, but we can't send two soldiers to the doorstep for the ones that are still alive.
Yes, that's a great point.
I mean, maybe it should be an internal function
or intervention of some sort.
Yeah.
That's a great point. You know, what I found, especially with soldiers, when you try to force them to do something, they kind of dig in too. So.
On the other hand, they understand discipline.
They do. Yeah, you know, I mean, and every situation is different. I mean, you know, a few months ago there was a 06 down in Florida who one of my colleagues or comrades at the VA knows or knew of him, and he took his life. And you know, just reading about it just didn't. You know, he was a colonel, you know, had everything going for him. I think there was a decision on either his benefits or his treatment at the VA that he wasn't satisfied with, and he took his life. I mean, you know, so, and you know, my first one was the E8. So, I don't know what the answer is. I just know that we got to continue to reach out to those veterans. And like I said, I have a friend now that you know, he and I used to talk almost every day, and then a year ago, he just fell off. And then about 3 weeks ago, he called me, and you know, he had lost his job, and he and his wife were going through some stuff, and you know, I mean, financially, he's fine. Mm-hmm. You know, I'm sure he probably has $1 million in the bank. That's how thrifty he is. But it's the other. He lost his father about a year ago too, so I think they may have had something to do with it. But you know, so when he calls me, you know, if I can, I try to stop what I'm doing and talk to him. And I hope he's going to be okay. But you know, I don't know. I wish I knew what the answer was.